Good evening, everybody, and welcome to our final breast cancer research and education event for 2021. We appreciate all your support this year, particularly with the online streaming. We've got a great session to finish off the year with some exciting speakers. I will remind you just how to ask questions, and we really encourage you to ask them as we go through. We do need to finish this session just a little early than normal. So normally we go to 6:30, but I think we'll be trying to tail up about 20 past or 25 past. So apologies for that early finish, but I'm sure you'll all appreciate that. So the Q&A function, you can chat or you can send us through your questions. Our session today really is relevant to anybody who sees any patient with breast cancer. The title of the session is The Impact of Breast Cancer Diagnosis and Treatments on Menopause and the Symptoms Experienced. And I think you'll all agree that these are conversations that we have in the clinic every day. The problems from our treatments that can go for many, many years. And I think it's relevant really across not just only medical oncology, but all of the professionals looking after patients with breast cancer. We've got two fantastic speakers. So Professor Yoland Antill from Cabrini and also an adjunct professor at Monash University. Yoland will be speaking first. And then we've got Professor Hickey, who's known to, I'm sure, many of you, who is going to go through the management of menopause after breast cancer. So as I said, I think we'll move through the two presentations one after the other, and then hopefully have some questions at the end. So thanks again, and we'll welcome Professor Antill to start. Thanks.
Hello, everyone. I am hoping that you can see my screen.
No, we can't see your screen yet.
Here it comes. Yep. Yep, perfect.
Can you see a screen properly now?
That's great. That's fantastic. Thank you.
Great. So I'm a medical oncologist and I mainly look after patients with either breast or gynecological cancer. So as Belinda alluded to, this is really my everyday, every appointment life. So menopausal symptoms, who does this actually impact? We know that the prevalence of menopausal symptoms really depends on the age at diagnosis of breast cancer, with those women who are diagnosed at a premenopausal age or around that perimenopausal age at the greatest risk. And it's also, you need to be mindful that many of these women will have received both chemotherapy as well as endocrine therapy, and chemotherapies can result in impact to ovarian function, followed by then the impacts of endocrine therapy. But I think it's also important to remember that a small proportion of our postmenopausal women will have been using hormone replacement therapy up until the time of their diagnosis. The breast cancer diagnosis hits and everyone says, stop, stop, stop. So again, that woman is essentially pushed into that abrupt onset of menopause. Many women who come to us are under the disillusion that the use of hormone replacement therapy is actually going to ease them into menopause much easier and mask the symptoms, and so that they don't have to suffer them. And when they stop their hormone replacement therapy, it will be all over. But in fact, it's all just going to start at that point. Approximately 80% of our breast cancers are estrogen receptor positive, and therefore endocrine therapy is aimed at minimising estrogen stimulation on estrogen receptors and, in addition, reducing estrogen production. So there are approximately 34 recognised symptoms of menopause, and these range from physical symptoms to impacts on psychological well-being, and things that you really wouldn't have been aware of, even the impact of an increase in allergic type reactions or these electric shock sensations. And it's not until you've been a breast medical oncologist for a number of years and you go back to one of these lists that you realise that these are the symptoms that appear in your clinics every single day. And initially, I really didn't think that some of them were related to either endocrine therapies or menopausal symptoms themselves, as I rapidly became a menopausal woman myself and experienced about half of them, I realised, in fact, that many of the symptoms that they were describing were related to menopause, and as such were often related to their endocrine therapies. So what's the risk of amenorrhea following chemotherapy? So if we look really at the bottom of the list rather than at the top of the list, so CMF and FEC or FAC and DAC are probably regimes used in previous years. But if we look down at just looking at, say, docetaxel carboplatin, there is still about a 30% risk of inducing a significant prolonged amenorrhea in women who you give this to who are under 40 years of age, and greater than that in women over 40 years of age. If we're just, for example, looking at the use of paclitaxel and trastuzumab, again, this was all menopausal women, premenopausal women of all ages, but again, just under 30% of those went into a period of at least partial, but if not permanent, amenorrhea. And then looking up at using the anthracyclines, you'll see that the rates of amenorrhea are even greater. And then we move into thinking about what endocrine therapies that we're going to use. So aromatase inhibitor therapy is more likely to be used in postmenopausal women, and this is a group of treatments that are more likely to be associated with certain menopausal symptoms, in particular arthralgias and insomnia, over tamoxifen. But then if you're using tamoxifen in a premenopausal woman and then add in a GnRH agonist, then again, you'll increase that impact of menopausal symptoms, and particularly again, if the aromatase inhibitor is used with that combination of GnRH agonist. The menopausal symptoms that are associated of any grade are more frequently reported in these combination studies with exemestane than they are with tamoxifen, particularly for musculoskeletal events, vaginal or impact to sexual functioning. And the use of chemotherapy preceded many of those women beginning the dual endocrine therapy, and remembering that these women might have actually already started to have some ovarian insufficiency during their chemotherapeutic regime. There is no doubt that the abrupt onset of menopause, whether it is caused by chemotherapy, surgery, the use of a GnRH agonist, or as I alluded to before, the cessation of hormone replacement therapy, is more likely to be associated with menopausal symptoms and more likely to be associated with symptoms of higher grade. So if we just look at tamoxifen and we look at hot flushes reported in women are younger than in those women who are older when they commence their tamoxifen, you can see that the rates of reported hot flushes is greater in that younger group than in the older group. And weight gain is something, again, that is reported more commonly in those younger women. But it's important that if a woman is very young and actually is not going through menopause as part of her tamoxifen use, so in her, then she may not experience as much weight gain. And you can see that in that older group who are already menopausal, the use of tamoxifen was in fact a less reported factor than in those pre or perimenopausal women who actually transitioned at the time they were starting to use their tamoxifen. If you then look at aromatase inhibitors, hot flush, and I thought this was quite interesting in that the hot flush reported rate was only 30%. We'll delve down into some of these subgroups in slides to come, but I think 30% of women on aromatase inhibitors is probably reflecting that this is a group that were already many years into their menopause before commencing their aromatase inhibitors. And again, similarly, quite a small proportion of women really compared to what I experience in my clinics of particularly young women starting aromatase inhibitors experiencing sweats associated with their hot flushes. Fatigue is very commonly reported, and insomnia and arthralgias, as I've already mentioned. But if you look here at this combination of a GnRH agonist with tamoxifen or the GRNH agonist with exemestane as part of the SOFT and TEXT studies, you will see a really marked increase in this reporting of vasomotor symptoms, musculoskeletal events, insomnia, and starting to get into the psychosocial aspects of impact of menopause. But surprisingly or not, for some, the vaginal dryness, actually the GnRH agonist didn't seem to make much of a difference over tamoxifen alone. But if you look here, it was a little bit more reported once you started to use the exemestane. So we now start to delve down into some of these subgroups. So fatigue is incredibly commonly reported by women who have experienced breast cancer diagnosis. But it is reasonable to assume that the fatigue is not going to be from one thing. Yes, it can come from the breast cancer therapies themselves, chemotherapy, related deconditioning and the fatigue associated with chemotherapy, if not anemia followed by surgery or surgery followed by chemotherapy and radiotherapy, all translate into increased levels of fatigue. But things like sleep disturbance, so hot flushes at night and causing sleep disturbance, increasing problems with depression and anxiety can also impact sleep well-being. Low exercise rates or poor exercise choices and dietary habits can also increase the likelihood of fatigue. It's also something that we've probably been a little bit more aware of, particularly as we've been shut up and haven't had to do so much of life's juggling act. But when you're juggling children, a job, a partner's career, your breast cancer treatments and all it entails, it can also add to fatigue. So when your patient says to you, I just feel so tired, it might not be about assuming that this is just related to their breast cancer therapies, and it would be really important to explore what else might be contributing to her fatigue. Now, this might cause a little bit of a ha-ha-ha moment, but if you think that in any one time, 1/3 of the world's women are in that perimenopausal or menopausal stage of their life, and that hot flushes are experienced by approximately 80% of women during that menopause transition, it's not really a surprising thought to think that menopause and hot flushes might be contributing to global warming. For our patients, the greatest proportion of women who report hot flushes are those, again, who have that abrupt onset of menopause. And you'll see this is a really commonly repeated theme in all of these subgroups. So that might be those women who've had chemotherapy or surgical induced menopause, or this addition of a GnRH agonist. We know, again, that these postmenopausal women who are suddenly ceasing hormone replacement therapy are plunged back into the very symptoms that they started to use hormone replacement therapy for. And almost always this was prescribed because of impactful hot flushes. There are fewer reports with vasomotor symptoms in women who are diagnosed with breast cancer with very established menopause in particularly in their late 60s through to 90s. In general, for those of you who don't know, a hot flush will involve a creeping sensation from the chest, face and neck, and maybe the back of the neck in particular. It can be associated with sweating, so hot flushes can be wet or dry, and they can be associated with erythematous change. They can also be associated with a real prickling or almost like an electric shock type symptom. They can last up to 5 minutes in most women, but can last up to an hour in a small proportion. They do evenly occur through the day and the night, but they seem to be much more noticeable at night, and particularly if it's waking women up. The perception of impact of hot flushes really varies in women, from non-bothersome to really severely impacting their daily life. If we look at the soft and text studies, grade 3 to 4 vasomotor symptoms were reported in up to 13% of women. Sometimes it's actually really helpful to tell women that a hot flush is actually a normal part of menopause. And once they realise that actually some of the things that might impact a normal woman, and not just a woman who's experienced breast cancer, it might not be just related to their breast cancer treatments, it can sometimes help them take charge and help to manage their hot flushes. But vasomotor symptoms are a really common cause of non-compliance or discontinuation of therapies, endocrine therapies, and particularly in the extended years. We know that non-compliance or non-continuation of treatments is much more common in our very younger group than our older group, probably representative of the fact that hot flushes are more impactful for younger women. It is fair to say that things like hot spicy foods, caffeinated drinks of any sort, stress and anxiety, alcohol, overdressing, or being in claustrophobic situations can all result in hot flushes. Hot flushes themselves can then also result in this real sense of anxiety and panic in itself. So the hot flush might not just be about a physiological symptom and a set of signs, but it might actually also be really impacting their psychological well-being. And again, recognising what might be causing some of the hot flushes and describing the fact that it can go on to cause these symptoms of anxiety and or even panic attack can be quite helpful in helping patients realise that they might need to manage their hot flushes a little bit better. So emotional well-being and anxiety and emotional lability, anger, sadness, teariness 1 minute, laughing the next minute, and anxiety all the way through into even panic attacks are described very commonly by women in menopause. And we've all seen these old-fashioned records of admissions even into mental asylums in the dark old days, where menstrual interruption, hysterectomy, or similar were causes for admission into mental asylums. We know that major depressive disorder and anxieties are more commonly seen at times of hormonal change during a woman's life, during puberty, during the luteal phase of the menstrual cycle, when they're postpartum, and again at menopause. A prior history of hormonal or related MDD or mood disorder without it being hormonally related are definite risk factors for repeated episodes. So in taking a history from your patient right at the outset and understanding whether mood disorder or hormonal cyclical emotional ability has been impactful for them may give you an insight into the fact that your woman may be at greater risk for these. Again, the more abrupt onset of menopause is associated with an increased risk of reporting of mood disorder by women. And as I said in the last slide, that these vasomotor symptoms are associated with an increased risk for anxiety and panic attacks, and particularly if continued and uncontrolled, resulting in depression. The diagnosis of breast cancer itself impacts emotional well-being. And this in itself needs to be weighed against the potential impacts of therapies and the potential impacts that other things might be impacting women and their emotional well-being or their psychological well-being at the time. But we know again that mood disorder is associated with an increased risk for non-compliance and cessation of endocrine therapy in particular. We also know from some work in Australia that menopausal and related depression following diagnosis of breast cancer really impacted women's ability to function in the workplace or even return to work. We know that from some general look at work in menopausal women, not necessarily related to breast cancer, that there was a significant proportion of women who felt that their menopausal symptoms in fact impacted their ability to carry out work in the capacity that they did prior to the onset of their menopausal symptoms. So not just a breast cancer thing, but translating back out into their normal and everyday work, and how do I even get back to the normal workplace? So vaginal dryness, again, is something that is very commonly experienced by menopausal women, described as either itching or burning or pain during intercourse, bleeding as a result of intercourse, pain on urinating, urinary frequency, or absolutely impossible cervical smears are symptoms of vaginal dryness, or what's known as genital urinary syndrome of menopause. It is, if not even more common, in patients who are having breast cancer treatments. But again, these symptoms can vary with different endocrine therapies. So we know that GSM results from estrogen deficiency. It results in an alteration to the pH of the vaginal canal, which means that it becomes more alkaline, and then translates to a change in the normal bacterial flora of the vaginal canal. And this in itself can be an irritating factor in terms of the symptomatology. Again, these symptoms are more severe in women who have an abrupt onset of menopause. Aromatase inhibitor use is associated with the greatest risk of vaginal dryness and dyspareunia than tamoxifen. Tamoxifen actually acts as an agonist and antagonist into vaginal epithelium, and women who are on tamoxifen do report greater vaginal discharge, but this can also result in increased itch over time, particularly as tamoxifen seems to really impact the pH for some women. And so a sudden increase in watery nature of that vaginal discharge, if someone's been on tamoxifen for a number of years, can potentially indicate bacterial vaginosis that may need treating. So GSM is different to female sexual dysfunction. Female sexual dysfunction includes an impact or lowering of libido, impact to arousal, orgasmic function, and genital and pelvic pain dysfunction, which can be incredibly disabling to ability to carry out exercise, sport, or even walking. The decrease in libido and impact to arousal or sexual function is very much more reported by younger women than it is for older women, but you should never assume that this isn't going to be impacting an older woman or older couple as well. Sexual dysfunction is multifactorial, and it can arise as a result of many things associated with a breast cancer diagnosis, including the diagnosis itself, the physical impacts of breast cancer, including breast surgery, an alteration to sensation around erogenous tissue, particularly around the nipple, and particularly in women who have bilateral mastectomy. Even with nipple sparing, the sensation around the nipple is never the same, together with the pharmacotherapy. Concerns around sexual health are incredibly common and reported in up to 90% of surveyed breast cancer survivors. Now moving to the musculoskeletal side of things, I'm not going to really focus on osteoporosis. We probably all know very well that osteoporosis is something that we need to think of, and particularly in women who become menopausal as a result of their treatments, or who already are menopausal and for whom you're about to prescribe particularly aromatase inhibitors. Osteoporosis is far more common than it is in men. 3/4 of cases occur in women over 55 years of age in the general population. Women lose 2 to 3% of bone mass per year for the first 5 years post the onset of menopause, but then they continue to lose around 1% per year thereafter. But the use of aromatase inhibitors increases that loss by 2 to 4-fold. And so that real loss of bone mass in that first 2 years in particular, when you commence an aromatase inhibitor, is something that I think everybody should be considering. 2 of 3 women will have an osteoporotic fracture during their lifetime. It's also important to remember some of the ancillary things that might help maintain bone strength are also something that we really need to consider for our women, given less than half Australian women eat the recommended daily calcium, and only around 35% of Australian women will take in recommended exercise regimes post breast cancer diagnosis. Joints and connective tissue. So I didn't really join the dots over this for a number of years after I started being a breast medical oncologist. Then I realised with increasing frequency that women were describing what is otherwise known as tenosynovitis. So we all know about arthralgias, but carpal tunnel, plantar fasciitis, frozen shoulder, tennis elbow, Achilles tendonitis, you name it, is all about this increased risk of tenosynovitis that occurs in women with menopause. It's really hard to find data on this relating particularly to breast cancer. There's a little bit of published data in menopausal women, and I think it's fair to say that it is incredibly under-recognised about the impacts that aromatase inhibitors and or other breast cancer therapies will have on these particular symptoms. So I have women who come back for an annual review to say, oh, well, I had both my carpal tunnels done, and then I had to have some surgery for my plantar fasciitis, and then I stopped their aromatase inhibitor and I put them back on tamoxifen, and suddenly there's this real relief of this just transitioning tenosynovitis that seems to be fairly migratory from joint to joint. But it is incredibly commonly reported by your women, and your therapies may be impacting. For my women who are on this combination of therapies, but I really do want to have them to have the benefit potentially of a DNRH agonist, sometimes switching back from an aromatase inhibitor to tamoxifen, you'll see a real downstaging in this tenosynovitis or enthesopathy. But it is still a pretty hard and continued battle for some women. Brain fog. So cognitive decline is definitely a part of the aging process, and really the onset of cognitive decline seems to commence at the time of menopause. The CNS is enriched with estrogen receptor alpha and to a lesser extent the beta receptors. It is an important part of memory formation and cognitive function. Again, the abrupt onset of menopause is associated with cognitive decline, particularly around verbal memory, and may have, so there are variable reports associated with dementia in later years, and whether the use of hormone replacement therapy in a non-breast cancer population will in fact reduce the onset of dementia. So chemotherapy-related fog is really well described and recognised, and probably you've already had a discussion about chemo fog in one of these education sessions. And to some degree, the chemotherapy fog is reversible, but it takes much, much longer and or is not so reversible if you, after chemotherapy, your woman is becoming menopausal. And these are the women where I just see cognitive impact over and over again that's described and impacting their ability to particularly work in their normal and pre-breast cancer capacity. So there is conflicting evidence over the impact of chemo and endocrine therapy, but looking at a large study of breast cancer survivors versus women who did not have breast cancer, there was increased cognitive decline, particularly around verbal memory and fluency, motor speed and attention and memory. The addition of cognitive function, again, can have some interplay with other factors. In particular, women who have significant sleep disturbance and or mood disorder. This can also impact cognitive function. And I know there was a real suite of studies that felt that the chemotherapy fog was largely related to anxiety around breast cancer diagnosis. So how long do all these symptoms last? So it does vary. Vasomotor symptoms can last from 6 up to 10 years in a small proportion of women, in women who are undergoing natural menopause. Interestingly, this may in fact be even of longer duration in women who are Black compared to Caucasian women. The genitourinary symptoms that arise during therapy can actually increase over time and may persist beyond the cessation of therapy. Arthralgias that are mild may persist again during the duration or beyond the use of particularly the aromatase inhibitor. But tenosynovitis seems to be more commonly described at the beginning of menopausal use or the beginning of therapies. And again, osteoporosis is for a longer effect, and neurocognitive effect longer still. So my patients describe breast cancer as the gift that keeps on giving. As an oncologist, and the management of breast cancer for many is going to be associated with a really high likelihood of survival. For the 80% of women with ER-positive disease where anti-estrogen therapies are going to be used to reduce the risk of recurrence, we know that the addition of GnRH agonists and aromatase inhibitors is superior for the premenopausal woman, but many women need to be treated to even prevent one recurrence. So should this really be something that you limit to those higher risk women? It does not really, I think, need to be something that needs to be used in all premenopausal women who are diagnosed with breast cancer, because the complications associated with these treatments are so pervasive and significant on quality of life. So as a breast medical oncologist, I feel we need to wear many hats: psychologist, psychiatrist, physio, orthopod, yoga instructor, Pilates instructor, dietitian, you name it, we have to wear it. But after this talk, I'm hoping that some of the symptoms that you're hearing from your women are starting to fit into place that may be related to menopause itself, the endocrine therapies, or the chemotherapies prior to the endocrine therapies. And now I'm hoping Martha is going to provide us some navigating ways in how to actually manage those symptoms.
Thanks so much, Yoland. I mean, you've certainly reminded us of things that I don't think pay enough attention to in our clinic. And as you can see, it can be a torrid time. So we'll move on just because we are pushed for time. Professor Martha Hickey, who's Chair of Obstetrics and Gynecology at the Royal Women's, will hopefully give us some pointers of the management of some of these toxicities. So thanks so much, Martha.
Off mute. Yeah, thanks very much. And thanks, Yoland. So I'm just going to talk about the management of menopause after cancer. The talk is about cancers generally, rather than specifically about breast cancer. So I'll just focus on the things that are most relevant to breast cancer. Oh, right, that's not advancing now. Sorry, I'll have to change it. Cynthia, I'll have to ask you to advance the slides, I'm afraid.
It's okay, that's fine.
Thanks. Yeah, okay, so this is for UK figures of the number of cancer survivors, and just making the point about the different effects of cancer treatments on women compared to men, particularly around menopausal symptoms, which, as Yoland mentioned, might be more severe than they are after menopause at the average age. And importantly, for the case of breast cancer, may cause women to stop taking their endocrine therapy, and also exacerbate the kind of symptoms that you commonly see after breast cancer, such as sleep disturbance and depression and fatigue. In addition, for those women that have an early menopause because of their breast cancer treatment, that itself might have implications for long-term morbidity and mortality. Thanks. So just making the point that it's not only survival from cancer that matters. Thank you. Just next one, please. So the kind of things that we are doing in our MSAC clinic at the Women's, and there are other clinics now around the country and around the world, are managing symptoms such as vasomotor symptoms, sexual difficulties and sleep disturbance. And we're seeing cancer survivors across tumour streams, and also women at high inherited risk of cancer. Next, please. So looking at vasomotor symptoms, first of all. Thank you. So I think it's important to remember in breast cancer that there are a few different reasons why women might be having these symptoms, and that might also affect their severity. So in younger women, chemotherapy or radiation for their cancer, ovarian suppression, as Yoland mentioned, after an ER-positive cancer, and bilateral oophorectomy, either as risk reduction for high-risk women or as part of their endocrine therapy. Postmenopausal women, fortunately, we don't see as many women being diagnosed on HRT anymore because there's less use of HRT, but also taking endocrine therapy that will commonly induce endocrine symptoms. And certainly our data have shown that it's the women who are on HRT when they're diagnosed with breast cancer who then stop and then go on to endocrine therapy that have the worst symptoms. Next, please. So what actually works for treating vasomotor symptoms after cancer? Next. So the most effective treatment is HRT. I'm not going to dwell on this in the setting of breast cancer because it's contraindicated in that setting. But it is thought to appear safe, at least in the short term, in women with BRCA1 or 2 pathogenic variants who don't have a personal history of cancer, although we don't know what the optimum dose and duration should be. Thanks. So in terms of non-pharmacological treatments, there's actually lots of available options now. Non-pharma interventions, so like CBT, very high quality evidence now to show that it reduces the impact of vasomotor symptoms, also improves mood, sleep and sexual function, and that can be delivered by a trained clinical nurse specialist or via the internet, something we could be doing across the VCCC. Hypnosis is effective in one small trial, and women referred it to gabapentin. Acupuncture has not been shown to be more effective than placebo. Next, please. So in terms of pharmacological treatments, this is an area that's really exploded in the last few years. There's 4 main classes of therapies, which are in the non-targeted or probably serendipitous group that I've listed there. And also there are now targeted therapies for hot flushes, which are neurokinin B receptor antagonists. They're not available on the market yet anywhere actually, but certainly not here. But in the future, that's something that we will have access to. Thank you. So just click through these, please. Okay, thanks. So that's quite a busy slide, but what I've tried to do there is put together the different interventions, different non-hormonal pharmacological treatments for vasomotor symptoms to give an idea about the sample size of the studies that have investigated them and how they compare to each other, because fortunately these studies all use the same outcome measure, which is looking at frequency and severity of hot flushes. And you can see that actual progestin is the most effective, but are not helpful in breast cancer. And after that, very small study in oxybutynin, but it is looking very promising. And you can see that there are a range of different things which are more effective than placebo. And also that there's a list there of some of the agents that are not any better than placebo. Thank you. And these are the new data on oxybutynin, showing, again, from quite a small study, but in women who've had breast cancer, that it's more effective. Both the doses at the high and low doses were equally effective, and the low dose had less side effects. So that means 2.5 milligrams of oxybutynin twice a day, increasing to 5 milligrams. We're using that now quite a lot in our clinical practice since publication of that study last year. Thanks. And this is an algorithm which we did for the BMJ a couple of years ago, but now updated with oxybutynin. And people want to know often what's the first thing that I should try if I want to treat hot flushes without hormones. And that's a difficult question because there's not much direct head-to-head data. But in our clinical practice, we use escitalopram or citalopram as our first-line treatment and then progress through the agents there. For women who've got primarily nighttime symptoms, we generally use gabapentin. It's quite effective for night. And oxybutynin, we're still working out where that fits into our clinical algorithm. But I think certainly in my clinical practice, the first thing I'll say to a breast cancer patient who has vasomotor symptoms is, do you want to take something? Because a lot of women will say no because they feel they've had enough medication already. And that's helpful in then thinking about the non-pharmacological interventions. Thank you. So sexual difficulties are a really common issue for cancer patients. I think the majority of cancer patients. Next one, please. So most women have sexual difficulties. Vaginal dryness may contribute, but it's often not the whole story. Everybody finds it hard to talk about sex. Next one, please. Vaginal estrogen does help reduce discomfort and pain during sexual activity, and it might also prevent recurrent urinary tract infection. It really is a tiny amount of systemic absorption. It's equivalent to taking about 1 milligram of estradiol a year to use vaginal estrogen. And we don't actually have anything else that works at the moment. The lubricants and moisturizers and gel are really not that effective. We did a randomized trial of a silicone-based lubricant and found it was better than the water-based one, but more than 80% of women still had pain during sexual activity. So that wasn't really, I wouldn't recommend it based on that study. Next, please. There's some data on intravaginal testosterone in women using AI for breast cancer, obviously. And because of the AI, they can't convert the testosterone to estrogen. It doesn't seem to increase circulating estradiol, but we don't have an intravaginal testosterone product in this country, and so we're certainly not recommending this widely. Next, please. So this data, this is Jason Abbott's data from Sydney. It's now published in JAMA about 2 weeks ago, showing that there is no benefit from laser over sham laser at all. So laser doesn't work. It was a really important paper accompanied by an editorial. It's worth reading, but I would certainly dissuade you from recommending laser to any patients. Thank you. So just moving on to sleep disturbance, thanks. So about 30 to 60% of women report sleep disturbance after cancer. And yes, we all understand it has a negative impact on your mood, concentration, and quality of life, use of sedatives and opioids. And really importantly, it's become clear that if there's a link between menopause and depression, that link is sleep disturbance. Thank you. So CBT is first-line treatment for sleep disturbance. It's effective, it improves sleep quality and fatigue after breast cancer. You can deliver it via the internet. But worth also knowing that a randomized trial data demonstrates that the use of hypnotics such as zolpidem does improve sleep and quality of life in women who've had breast cancer. So don't rule that out in your clinical care. Melatonin reduces time to sleep onset by about 20 minutes. So not, a small benefit. Thank you. So here are some sleep options, some CBT sleep options. Can Sleep is something that we've developed at Peter Mac, been led by the psychology group there, which is a program of stepped care for people with sleep disturbance after cancer. Thank you. So how do we manage these symptoms, common symptoms in clinical practice? Next slide. What we've found across tumour streams is that often cancer management is gender blind, particularly in cancers that affect men and women, such as colorectal and hematological cancers. When we did our stakeholder consultation, and this was basically me and Christabel Saunders about more than 10 years ago now, we found that menopausal symptoms were commonly dismissed. A third of women reported dissatisfaction with their consultations. They wanted their common symptoms managed in one place. They wanted easy access to services, and for that reason we set up a video telehealth service a few years ago. And they wanted coordinated care between their providers. Specifically, they didn't want one doctor telling them to take something and the other doctor saying, don't take that, it'll make your cancer come back. And that was something that was happening, unfortunately. Next slide, please. So this is a model of care that we've set up. Patients referred from an oncologist, a breast care nurse, or from primary care. We see them in person or through telehealth, guidelines for the tumour type, patient information support reviewed by the nurse specialist, and we use resolve management issues through a multidisciplinary team, as is best practice in cancer. Thank you. This is a new program we're starting up called Women Can, which will be a web-based program for managing menopausal symptoms after cancer using step care, trying to get a better reach to more symptomatic patients in the community. Thanks. So this multidisciplinary model of care, we see about 3,000 women in Australia every year. It's been implemented in various other sites, and we feel our patients seem to be happy, and we hope that the referring doctors are happy to have a service that focused on managing symptoms in their patients. Next slide. So we have a multidisciplinary team, as indicated there. Not all of those people are there at any one time. We've basically integrated this into an existing menopause service, but trying to provide joined up care for our patients regardless of their cancer type. Next slide, please. And these were some figures from a couple of years ago now. We started off just for breast, but now we have a lot of many patients from other tumour types. Thanks. And this is something that's available if anybody is managing women at high risk of breast and ovarian cancer. These are information booklets for women. And the next slide, please. Also for healthcare professionals about surgical menopause. So it's about the consequences of oophorectomy in premenopausal women. Next slide, please. And this is the model of care which adapted slightly different for our high risk women, who we try and see prior to their oophorectomy to make a plan for how their symptoms are going to be managed post-operatively, and then follow them up until that's stable. And we're just writing some guidelines now for clinical care after a risk-reducing oophorectomy. Next slide. I'll just skip over comma, actually, in the interest of time. Next. Okay, so just go back to the summary, the previous slide there, thanks. So just to say that menopausal symptoms are common after cancer treatment. There's a growing number of effective treatments available. Nearly all the evidence comes from breast cancer. Treatment of those symptoms improves quality of life and may reduce mortality directly from women taking their endocrine therapy and indirectly from reducing chronic disease. And multidisciplinary care is cost effective and avoids women going to multiple appointments with different specialties. And our research platform ensures that women's voices are heard, or so we hope. Thank you. Next slide. Yeah, okay, that's all. Thank you very much.
Thanks so much, Martha. I know you've got to go early, but could we just, and maybe Yol, you can come online too. We might have a quick panel discussion. Can I start just by asking you, I mean, the interesting thing about our addressing of the side effects is, particularly when we start women on AIs, is we wait for them to fall apart and then we do something. And I'm thinking, you know, should we be kind of thinking even before we start the AI? I mean, particularly in our high-risk women, they may have had chemotherapy. We've had months and months of setting them up. And yet we kind of start them on the AI, wait 3 months or 6 months, and then begin the oxybutynin or the venlafaxine, or refer them when we run into trouble. Is there any data to suggest that we should be taking a prophylactic approach, or you've really got to wait until the side effects come on? Because I think you can often predict which patients this is going to happen in.
No, I've never seen a study that's done that. I mean, I understand what you're saying. I suppose not everybody's going to have a problem, are they? So you might end up over treating, I guess. Although, you know, if you took the model of pain, you would think that treating early would be better.
Yeah, I mean, or thinking of CBT, I mean, it might seem, I don't know whether prophylactic CBT does, sounds crazy. You've got to have the symptoms so that you can manage it. But, you know, I think some of these, you know, obviously these have multiple prongs to be able to help patients. And I do worry sometimes that we're just very slow. We're often just too reactionary in this setting.
So, Belinda, one of the things that I think we can see, particularly in the younger woman who's having chemotherapy prior to the onset of potential oophorectomy or endocrine therapy, is that this is the place where you can really start to address some of the psychosocial issues and call on your psychology supports and start to get some behavioural therapy started to manage. So some of the anxieties start around the actual diagnosis of breast cancer, so that then if you need to call on that again, they've had that previous experience and being able to utilise that to manage the anxiety around the diagnosis. But I think also acknowledging, as those hot flushes are starting to increase and the fact that their anxiety levels might not be settling down, it's okay to voice. Do you know, does your anxiety actually get worse when you have a hot flush? Yeah, no, it really does. Then actually what you need to do is manage the hot flushes to help kind of try to manage that anxiety. And the other thing I think is really important as groundwork is getting them into these habits of exercise and dietary well-being, because I think that the woman who is still having, you know, the glass of wine at night and having a carb-rich meal at night is not going to sleep well. She is going to have hot flushes. She is going to have, you know, just that poorer sleep. Then it translates into more fatigue. So then they get less, want to go and do exercise because they feel tired, and it sort of ends up back being that vicious circle. So I think there is a real role in starting those things early before you've even started their endocrine therapy, particularly while they're having their chemo, if that's what they're having.
Mm-hmm. And maybe to either of you, I mean, I don't know, it seems to be everybody is on either melatonin, an antihistamine, or a benzo, and I'm amazed. I mean, every single patient, I mean, I don't know what's on the telly, but they seem to be given out like lolly water. I mean, is this okay? I don't know. Does melatonin, are there any problems?
I think it works in everybody.
I don't think it's been shown to do any harm. I think the main thing it's shown to do is not work, I think.
Yeah, I mean,
and most people don't like the antihistamines. They're very sedating the next day. Even low dose, I think, you know, they're quite sedating the next day.
It's amazing how powerful these ads are. Martha, a question about evening primrose oil, no better than placebo? No. And maybe a question for you, Yo, about treatment breaks. If you're giving a treatment break, how long should you do it in order to see an improvement?
So I really see in the joint symptoms, so arthralgias themselves, that 4 weeks is enough to understand whether the aromatase inhibitor is causing the arthralgias. We know with women using extended adjuvant therapy, the SOUL study gave women 3 months off of every 12 months of extended adjuvant therapy, and really seemed to reduce the impacts of adverse events associated with the extended adjuvant therapy, and I use that a lot in women who are going to need to think about 5 through to 10 years, if not more, of treatment. For things like mood disorder or the tenosynovitis, I don't know that there's a right time.
Thanks.
No, thanks, Martha. I realise you've got to go, but we can thank you so much for joining us. Yes, so yeah, I mean, I think sometimes you do need to stop them. I find actually for a bit longer. I love drug holidays. Actually, I use them all the time because it can really convince someone. You know, if they're a new woman, so to speak, it's all me, it's all the drug, and sometimes sadly they're not, because they're also going through this background, you know, menopause, as you've talked about tonight. Maybe just last week, because I realise you've got children who have just finished their exams and there's a huge party behind you, but what are you doing with tamoxifen? Are you using, with that data that we've seen, less might be just as effective? Are you using 10, or dare I say?
No, I haven't done that. I must admit, I have been very tempted in the preventative setting, and particularly those who've had a DCIS and there's a bit of a family history, or there's the family history of lots of breast cancer but no gene to explain it. So they're those women who've got, you know, lots of women with breast cancer in their 60s plus. I think that there's a real role for 10 milligrams of tamoxifen, but I haven't gone to use it in the adjuvant setting.
Okay, excellent.
Have you?
Look, I have. I mean, particularly if I've got a lady who, you know, I guess particularly we're talking about ladies where we've de-escalated aromatase inhibitor, tamoxifen, and then it's, you know, it's nothing or something. I have actually used that data. I've said to them.
Oh, I've used it in cases,
yeah.
Absolutely. And sometimes even secondarily.
Yeah,
to keep them on something. But I often wonder, Belinda, if these women that are getting incredible menopausal symptoms are actually getting more benefit from their tamoxifen. So I think something, I rationalise to myself, something is better than nothing.
Yep. Actually, Giselle's got a question. We didn't bring it up, but have you got a magic answer for hair thinning?
So I think it is a real thing. It's something I get asked for all the time, and acknowledging it again. I think it's more common in the women who haven't actually had chemotherapy. Chemotherapy seems to, if providing they haven't had a docetaxel, then their hair grows back a lot. But in the women who are just on endocrine therapy, they get their real thinning around the crown, they get real thinning around the temples, and the other women again who really notice that are the women who've been on HRT and have had to stop. But no, I have no magic cure, and I don't believe that the whole minoxidil, spironolactone, and whatever the other third thing is, I don't think it makes a difference at all.
Yeah, all the super expensive shampoos out there. I'm amazed how people can. Yeah, I haven't had great success with either. So sorry, Giselle, we haven't got a great answer to that question. Look, on that note, can I thank you very much, Yoland? We thank Martha, although she had to jump off. And thank you all. You've been fantastic in joining us for the year. I hope you guys have learned something across the year. We hope to recycle these sessions, and anyone with suggestions for topics next year, let us know. Join us next week. There's a grand rounds on Wednesday with Professor Claire Phillips. And in terms of the education series, what we'd like to say is have a wonderful summer. We hope you get to have some fun with your family and friends that you have probably not had. And we'll see you in 2022. All right. And thanks, Cynthia and Jasper, for keeping us on track this year. Have a great night, everyone. Bye.